with all of the electronic changes in medicine, not seeing your doctor in person, telehealth and all of that, it made it easier for doctors, I think, to see more patients. It kept people from having to drive all the way to the doctor's office if it wasn't something that they had to see the doctor in person. Made it easier to talk to your doctor. But, of course, they found a way to charge you for that. A new study shows that fees coming from some institutions for an email, $3 to $100. No joke. $100 for emailing your doctor. Paul Seegert worries that this price cap on Medicare will also damage people. He's a managing partner at PCS Advisors, a health benefits consulting firm, 35 partner offices across the nation. About this fee, Paul, good to have you back, by the way. Good to talk to you again.
Yes, you too. Good morning.
What about $100 for an email? I mean, $3, okay, maybe I could stomach that, but $100 for an email?
Yeah, as soon as you can get something approved where you can bill it through insurance, and really Medicare often takes the lead on that. As soon as they say, yes, this is a billable service, you can be sure it will find its way into just about every health plan. And that's what we're seeing here. If you spend the basic rule for an e-visit, as it is called, if the doctor spends anywhere north of 5 minutes in the course of a week dealing with a patient via email, so normally maybe changing a medication or giving them some sort of advice, then they can bill for it. And we're going to see a wide range, and a lot of it get buried into your future premium, as is often the case.
So as we continue to see this shift into this virtual world, it almost seems like they're discouraging people to see the doctor. Again, it's like, don't see the doctor. If you see the doctor, we're going to penalize you for seeing the doctor. Why is that?
Right. Yeah, we have the best healthcare in the world. We're not that great at paying for it. Here's a good example, I think, in this situation that we're, in a way, I mean, they already have studies that are showing this does discourage people from reaching out to their doctor because they have some uncertainty around what they're going to have to pay for that. Lots of them are in high deductibles where that whole charge might fall on them, and they'll get a bill after the fact. And then it just contributes to our bigger problem where we've stomped out primary care or made it less and less accessible so people don't get the things they need early. Instead, we wait until you have a big, massive event where real billing can occur and you end up in an ER.
Yeah, where real billing can occur in the ER. By the way, I learned something from you recently, and I think this is as good a time as any to share with people. It used to be, speaking about going to the ER, that indigent people that couldn't pay the bills, people that didn't have insurance, you have to be treated anyway. And the way that it was made up was on the backs of people paying insurance. They'd charge 2, 3, 4, 10 times maybe what a procedure was worth that the insurance company would pay it, and therefore the hospitals or the medical facility made up for that. But now we've crossed a Rubicon, crossed a threshold where 51% of the people in America, you say, are getting some sort of government payment for their health care, which means
that's right.
There's only 49% of us picking up the rest of the bill.
That's correct. And shrinking. I mean, it's, to me, a really alarming trend to watch, especially when you understand how all the money moves in healthcare in our system, where private payers or commercial payers, those that get their healthcare at work, we support the profitability of the whole system. The quality that we all enjoy is only possible because someone shows up at that hospital and their plan pays on the low end 200, 250% of what that hospital receives when they treat a similar person for the same procedure that may have Medicare or Medicaid. And that 20 plus years ago, 2 out of 3 of us got our coverage at work. So those numbers worked. I mean, the government was able to essentially underpay providers because they knew they could make it up on the employer plans that would show up in their door. But now we've created, especially in this last 12 years with the Affordable Care Act, we're pricing more and more small employers out of being able to afford to offer coverage and pushing more people into programs.
And so it just feels like it's spiraling downward, because if we're at that threshold, if we've broken through that, right, then we're already almost to socialized medicine, which is terrible Because then the best health care in the world that you just mentioned, we won't have anymore.
Well, yeah, the system won't, the dollars won't go into the system to pay for it, frankly. And you can only ration something two ways, price or line. We've always opted for price in this country. Our peer countries do line, and I think a lot of Americans just don't realize that having coverage and having access are not the same thing. You can say that everyone in your country is on one system, they all have coverage, but if they have to wait months to get services that here you could get in days or a week or two or three, that's a big difference.
It is a big difference.
We have to navigate this better and retain that while figuring out the financial side of it.
Yeah, the financial side of it, though, the more the government gets involved, the worse it is. Gee,
the worse it'll get.
That's different. Yeah, that's different. I mean, everything the government touches turns to, well, it's a family show, but you get it. Yep. Paul Seegert, great conversation. PCS Advisors, health benefits consulting firm, 35 partner offices across the nation. Does this every day, knows what he's talking about. Paul, always appreciate your contribution to the conversation. Sometimes I feel better about it, sometimes I don't, but at least I know what's going on, and I always appreciate that.
Yep, I appreciate it as well.
All right, have a great day. There you have it. Paul Seegert, everybody.